So hello and welcome to today's Age Well webinar. My name is Alison Schneider, and I'm the Education and Training Manager at Age Well, Canada's Aging and Technology Network. In today's webinar, From Problem to Pilot, a practical approach to everything AI, translation, and home care, we will explore VHA Home HealthCare's AI translation pilot as a case study, or a real-world example of an end-to-end repeatable approach to moving from problem identification to solution finding, to implementation, and finally to evaluation. In this webinar, we'll hear from Jordan D'Souza, who's here, who is the head of innovation at VHA Home HealthCare. We're excited to have you here. Okay, so a few housekeeping notes. So this presentation will last for about 45 minutes, and that means we'll have 15 minutes for Q&A to follow. You may post any questions or comments you have for the Q&A in the Q&A box, if you can. There you can also upvote and add comments on the questions if you'd like. You can also post in the chat, but try to vote in the Q&A if you can. You can also raise your hand to ask a question verbally, and the raise hand option is in the Zoom toolbar. Also in the Zoom toolbar, you can find closed captioning. So if you'd like to enable this for the session, you can do that. This webinar is being recorded and will be available for replay on AgeWell's YouTube channel. All webinar registrants will be sent a link to the recording as well as any resources we might share during the session. Okay, so that's it for me. I'm going to turn things over to Jordan to start his presentation.
Awesome. Thank you, Allison. And first of all, I just want to say thank you to AgeWell for allowing me this opportunity to talk about what we do here at VHA Home Healthcare and our project of AI translation. I know that it's a very interesting topic, and it's very, I think, timely topic, especially as the AI wave is you know, in the healthcare space. But I just really quickly want to be clear about what this, presentation is and isn't. So it isn't a pitch for a single tool, and it's not meant to suggest that AI replaces any human interpreters. It's a story about the process that we took to implement and evaluate an AI translation solution in our organization. It's a look at a real world messy problem in home care and how we move through it through a structured but practical evaluation to get behind a decision that we can stand behind. I want to start off with a land acknowledgement, and I want to say that the land that I am standing on today is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, the Williams Treaties, signed with multiple Mississaugas and Chippewa bands. I also do want to say that as the weather's getting slightly warmer, please go out and enjoy the lovely weather that we're having. And maybe there might be some greenery on the leaves sooner than later. This slide, I think, is really kind of the backbone of the entire talk. So innovation often jumps to what tool should we buy right away? And as an organization, we really forced ourselves to slow down and think about this process that we have right in front. What the problem is, are we ready? How do we scan for solutions? How do we sift through the solutions? What does the pilot look like? What are we implementing? How do we evaluate? And then ultimately, what do we decide? And although it looks like a very simple process, just one line straight across, it entails a number of questions. And these are just some sample questions that arises when you're talking about each stage of this process. So every step here really represents a different type of opportunity, but also, like I mentioned, that swath of questions. And these are the kind of questions we use in an innovation portfolio to reduce excitement-driven decisions. It's always I always ask my team, hold me back, because I'm very much like a dog chasing the latest car that's passing around, and I really want to remain grounded and make sure that everything that we do is well thought out and, like I said, grounded in reality. The early stage questions you may have noticed are around clarity and readiness, and only later really do we get to that: does the solution fit and should we scale? For AI translation specifically, we use the same approach. Make sure it's a real problem, confirm the change appetite in the organization, scan broadly, then sift using criteria that reflects the home care constraints, and then the rest of the processes. Here's how I'll structure the session and a kind of high-level agenda and learning objectives. First, we'll talk about kind of the problem statement and the current state, and really kind of really understand how to define a problem and gauge that organizational willingness for change. Secondly, we'll build that implementation plan. It may differ from organization to organization, but I pulled out some high-level steps that I think are applicable to multiple organizations, and really kind of supporting that frontline or point of care adoption, including elements such as user access and onboarding, authentication, privacy and security, training and support. Lastly, I'll talk about our results, which are our findings and understandings. But before I jump too much into that, to give you some context, of course, who am I? I'm Dravinder D'Souza. I'm the head of innovation over here at VHA Home HealthCare. And this photo over here shows my youngest, who is now 11 months. I think she was maybe 6 or 7 months in that photo. And my grandma over there, who was 102. She passed away in December, but she received VHA services for the last, I think, 12 or 13 years of her life. So, many times we think that this is a problem that, someone else has, or this is a problem that someone else can solve. But reality is that we're all aging, and innovation, especially in home healthcare, has a role to play, I think, in everybody's life. And it may not affect you directly, but it will definitely affect your neighbor or affect someone that you love or a coworker or something like that. So that's a little bit about who I am. The portfolio, the team that I work with is the innovation team at VHA. Really, our motto is deploying technology that preserves independence and promotes healthy aging in the community. We have an innovation pledge where all the technology that we look at is high quality, backed by science, and safe and secure. And we only really work with technology that we've checked. I'll go a little bit about the process of how we check that technology. Our team fluctuates. It's a very small, nimble, agile, and excellent team, including Philip Wood, who is the innovation associate, as well as two innovation intern roles who have actually played a really good and really a big part in this pilot project. We also work with clients, families, and caregivers to remain grounded in our community innovation lab. It really helps us understand and validate technology and innovations in the real world. Also, a little bit about VHA Home Healthcare, so kind of getting a little bit bigger over here, but I'm sure many of you know, but if you don't, VHA Home Healthcare is a non-for-profit charitable organization that is often abbreviated as just VHA. We offer 24/7 kind of healthcare and support services in the home and community care space to people of all ages and cultural backgrounds. The home care context is, or the home care is really kind of an important context over here because we work in uncontrolled environments, noise, family members, time pressure, variable internet connectivity, traveling across the GTA. So when we talk about digital tools, we're not talking about, quiet clinic rooms with a desktop computer or a residence where, a nurse is on the floor. We're talking about kitchens, bedrooms, unshoveled driveways, non-salted stairs in the winter. And really, it is as diverse as the homes and the people that we serve. We're actually 100 years old, so last year we blew out a lot of birthday candles, and through the years, I think we've stayed true to the vision of providing that highest quality, compassionate care to vulnerable populations, and really kind of ensuring that our clients can maintain their independence and live safely at home. I wanted to put the slide up front, just because it's always saved for the end. But this project, this pilot, wouldn't have been possible without many people, including client partners and caregivers, including previous members of the team, including other folks from different departments such as digital or privacy and security or operations and quality and best practice, as well as kind of our innovation advisory committee. And this also kind of plays a role into kind of what supports are needed to make a project like this successful. or are needed to be in place to launch a project like this. This really kind of wasn't innovation to staff. This was innovation with staff and really bringing, everybody on as a partner. Not only gives them kind of a stake in the project, but also allows you to converse freely in a more positive environment. So thank you to everybody who participated in this project. Of course, some of you may know Ron over there. Okay, let's get into it a little bit. The core problem is simple to say and kind of hard to solve. Language barriers undermine safe and equitable home care. Staff may encounter many languages in a single day. It's as common or as easy as jumping on the TDC and you're in the subway and you can just hear all the multitude of lovely languages around you. And informal workarounds are quite common when translation supports aren't accessible. So, there's a couple images over here talking about when translation or showing when translation may or may not work the best. For example, I'm not sure of what a wheelchair accessible trail really means, or if you're parking and there's multiple signs saying don't park here or park here at this time, but not at this time, really kind of translating what the message means is what's important. And home care kind of makes this harder because we cannot control the environment, the timing, or who else sometimes is present in the room. Is this a unique problem? When I started this project, the first thing that I did was I looked around and I looked at other home care agencies and I looked at other healthcare agencies and I said, is this unique to VHA? I'm sure someone's gone through this problem. I'm sure someone has tackled it in some way, some shape, some form. And they have, but not in specifically the home care context. So during part of the environmental scan, it's always important to take a look out there and see if someone has solved this problem and adapt it to kind of what you can do. And care happens in, as I mentioned, those uncontrolled environments. Maybe it's a dog barking, which is very common. Maybe it's like one of my two cats, which meow very loudly, and I hope you don't hear them through this webinar. Or maybe it's someone playing music and enjoying, the latest Bruno Mars song. Um, Miscommunication in these type of environments can really pose a risk to safety, can pose missed care needs when someone is afraid or doesn't know how to convey the feelings that they have or convey maybe health issues that they have. It sometimes provides an inequitable experience where sometimes maybe you can talk to some care provider, but you can't have a conversation with another care provider, so you don't say something, and really leads to kind of moral distress for staff because our staff really do care and they really want to provide that best care. What does this actually look like? So there are a lot of informal workarounds when formal interpretation isn't immediately available. Our staff do what they have to do. Gestures, simple words, using family members for interpreting, or maybe using kind of free translation apps, which may not, hold to the highest regulations of privacy and security. Or, they may just avoid complex altogether. I'll deal with this another time, or maybe I'll get someone else to translate this, or I'll follow up later if I remember. That's what could happen. And what it really risks is, as I mentioned before, that inconsistent quality of care, privacy concerns, delays in care, reduced confidence, and that inequitable client kind of experience. Um, our baseline data, and I'm not going to jump right to results, but our baseline data from the pilot showed that staff confidence was just at 2.5 out of 5 when communicating across languages. And really, that's not a technology problem. I think that's a system problem. I did say this at the start, but I want to be very explicit about this, that human interpreters are the gold standard for complex and high-stake conversation. That does not change at all. But there are real gaps. Immediacy, administrative burden, scheduling a translator ahead of time, and then realizing the snowstorm has delayed your visit by 2 hours, and is that translator still available? What is the cost to having a translator when you're delivering care? And then how does the privacy dynamics play a role kind of in a home setting where, maybe someone wants to share something intimate, a health concern that's intimate, and maybe they don't want their family member to hear or someone else in the house to hear, right? How does that play a role when you have to say it out loud, uh, or you have to use a third party where they're already opening their home to one care provider, and now they have to tell their story to someone on the phone that they've never met. It's they're in a very vulnerable state. Translation tools can also serve as a supplement for routine interactions. So introductions. If I recorded who I am and what I do, I'm pretty sure I can translate, and I'm very confident I can translate that into other languages and be confident that it's saying the right thing, as well as kind of basic routine questions, hello, how are you doing? My name is Jordan, so on and so forth. Um, Before scanning the market, one thing that I did was with the team is look internally at the organization, asking ourselves the hard questions. Is this a real problem, that we own? Is this a problem that it's ours to solve, or is this something that we're going to let other people kind of solve? Do we have leadership permission to pilot and to learn and not just succeed? Do we have the capacity? And are there guardrails in place? If the answer to any of these had been no, we would have stopped right there and tried to build the support needed within the organization. Our first step was an environmental scan to understand what exists globally and to map to major kind of solution categories. We have a white paper that we've developed that where we group kind of solutions into categories such as a portable device, a web/video conferencing translation solution, human interpreter platforms, and lastly, smartphone-based translation apps. We really wanted to identify categories that could realistically work in home care. And with the lens and the environment that we have, we really found that smartphone-based translations apps were the way to go. Um, Apps are kind of leading the way. It's a very easily scalable and deployable kind of technology. And as our workforce is extremely mobile, there's no extra hardware to bring around. There's no translation device that you've got to remember to charge, and you have to make sure that you're logged in and that it's connected and that it's working and that it's clean. There's none of that worry if you use kind of your mobile device or use a mobile device. It's also kind of a better fit for routine kind of in the moment interactions. I'm sure everyone has mastered the art of pulling out their smartphone. I know like mine's almost like I can just draw it quickly from my phone, check something, check some notifications, and really kind of leaning into this technology that's already widely used is what we saw was easier to do. It was also easier to pilot kind of with diverse roles and regions. So when I talk a little bit about kind of the participants, it wasn't only limited to specifically the GTA. Then we moved kind of into the first way of kind of looking at these solutions, which was um, looking at our decision criteria before even kind of looking at the vendors. So this is where kind of we pulled in people from our quality team as well as some researchers to really define the criteria that mattered in home care. And it played a role in sifting vendors and technology partners. But as you see, it also played a role in evaluation, seeing what makes sense for the organization and the outcomes of the pilot. So this is as much as I try to do it, this is a kind of two birds with one stone. We looked at elements such as kind of accessibility, privacy and security, of course, adaptability, language coverage, availability across devices and connectivity. So making sure that if someone's in a basement or in a concrete building where there aren't antennas built in and they don't have access to Wi-Fi or internet, that they can still rely on a translation solution, as well as kind of transparency on pricing. That's incredibly important and an element not often talked about, I feel, in healthcare is the price of solutions. And then lastly, very important to us was kind of that support model and reliability. I'm sure that everyone knows that if you own a car, sometime sooner or later something is going to go wrong with the car. And it really matters about how easy it is to fix and how kind of often, or not only how often, how easy it is to fix and how readily available kind of the parts are. So Really kind of by bringing these two groups together and by building kind of this decision criteria before meeting with the vendors, it was a small step to try and eliminate kind of biases that may exist within ourselves. We actually did a second sifting step where we brought people to the demos and we asked them very pointed questions, asked the technology partners very pointed questions, such as how does it work in a real care interaction, right? There's a very scripted demo, and I'm sure you've heard it that, or I'm sure you've realized that I am very scripted when I talk about the organization, but I really wanted to see with these translation tools how it works in the real world and without a script. So very much we were like, can we try it out? And on this demo, can we have this conversation and see if it translates correctly? Um, we also asked, how does a staff member validate the meaning? What methods or what ways do you have that shows that what you're translating is actually, what you're saying and maintains that original meaning? Very important to healthcare organizations is obviously security and privacy. So, how's data processed? How's it stored? For how long? Is the information used to train the model? Is it kept separate from that? What controls exist for consent and auditing? How do we, perhaps check logs and see how many times translation was used or if it wasn't used? Also talking kind of about the real nitty-gritty stuff of operations and support. So how do users get access, right? Is it just they click an app on their home screen? Do they have to scroll through their app drawer? How do they make sure that the app is up to date? How do they know that it's up to date? How are they confident that they can use it? And then other elements such as how quickly or how often do we need to train them, right? I don't think there's any training for like apps like Google Translate, and it's very intuitive. Nor are there like trainings for Google Maps, but I'm sure that they exist if people need that support. So how do we adopt a model that's very intuitive, but also allows like super users to really dig in and use the depths of whatever translation app that's out there. Also, something is kind of what's that escalation path when it breaks? If something's not working, if the translation is freezing, if it doesn't do the text to voice, where do we go? What do we do? Is there a contact number over there? And then lastly, and this was an important question to us, was what transcription machine does the solution use? So not only going out there and looking at kind of the vendors, but also understanding the technology is very important when doing a pilot like this. Our pilot design also was shaped through our Innovation Advisory Committee, so our IAC over there. Our IAC, our Innovation Advisory Committee, includes point of care staff, includes client partners, as well as caregivers and organizational leaders. So this is one of the foundational kind of structures that exists within the organization and within the portfolio that really allows us to tap into what the organization wants and gives us that initial feedback, gives us that yes, no kind of advice on pilots and on projects that we're looking at. We had kind of structured demonstrations, and we asked the technology partners to demonstrate to members of our ISC what their solution does. We collected kind of a little bit of that feedback. They helped us refine also the criteria of how to select a solution and not, and also feedback on kind of the best implementation approach. A little bit about kind of what that looks like in kind of one slide over here is that we ultimately ended up with three tools selected as our kind of test cases for this project. They are Mabel AI, Care to Translate, and Microsoft Translator. The way we got to them was through kind of that process I just described. That first sifting step where, we looked at a wide range of technologies and we eliminated ones that didn't fit into kind of the mobile apps criteria. The second one where we looked at the solutions and we really thought to ourselves, what makes sense in the home care context and what doesn't. And then the last one is that co-design process with our IAC, where we essentially ultimately end up with 5 solutions. But you may notice that 5 solutions to 3 solutions, like how do we get to kind of that space? Well, this is where kind of understanding the technology or the innovation kind of really makes sense and is really important. So taking a look behind the scenes is important for us, as I mentioned. But very quickly, how AI translation works is that it's first speech to text, so transcription, um, dictating something, maybe Microsoft Dragon, if anyone was around and using dictation software in 2002, I think. But Dragon software was that early kind of transcription, making sure that what you're saying is transcribed down. And then that text gets translated through a translation model. And then that translated model or the translation text then gets, text to speech where it's read aloud. And what was really important for us to look at was that transcription model. There's also other elements that AI translation has where there's a conversation mode where you talk, it recognizes that there's a pause, it translates, then it pauses and listens, and then allows the other person to do the same thing. And that way you can have a conversation without having to press, the button or the buttons to kind of have that conversation. There's also things such as phrase libraries where if it's a very commonly set or routine translation that you want to use, you can use that. There's also kind of validation prompts and then translate back. So this is like letting someone or seeing what you translated translate back into, for me, English. And the transcription part was super important for us in the home care space because one word can definitely change the meaning. Domain kind of language can be mistranscribed, leading to mistranslations. Some examples in the home care space that I've seen and that I've heard were, possibly an issue were like the words such as walker, right? If you're going to walk more than 10 meters, please use your walker. And it may be translated as someone's name, but that's not what it is, right? It's a mobility device. Other words such as transfer or discharge or wound, or even acronyms such as OTPT, which is occupational therapist and physical therapist, may be translated or transcribed and translated incorrectly. So we really kind of valued and put emphasis on tools that supported kind of that validation and confirmation of the translation that we wanted. We also looked at kind of repeatable phrases because, a lot of clinicians use a very standard process of identifying and triaging issues. And we wanted to make sure that the organizations that we were looking at and the technology partners that we were looking at were kind of healthcare oriented. What did kind of the pilot implementation process look like? Well, the live pilot ran from June to August, while participants kind of across disciplines and regions used the tool in real client interactions. We had 40 initial participants spanning these different kind of roles, and our approach was really kind of starting with that baseline interview and then end of pilot interviews, where we kind of chatted with and had conversations with participants in this project. One thing that was really interesting and always amazing, I'm sure, in any pilot is champions. And the champions that arose, we had multiple check-in points with them because they love to share their feedback on the solution and if it was working and where it excelled and where it didn't excel. And this in turn allowed us to have conversations with the technology partners of, hey, we noticed this about your solution. Are you going to make a change? Are you willing to make a change? What does that change mean? And a little bit of that comes out in the results. What also did kind of implementation mean in this pilot? Implementation is part of the intervention. And this was kind of one of the biggest lessons that I learned. During kind of our orientation, we really outlined that this is what AI translation is, and this is what AI translation isn't. That hands-on demo and practice scenarios were absolutely critical to ensuring that everyone kind of knew what the solution was. We also wanted to support people getting their hands on the solution or yeah, getting their, I guess, their fingertips on the solution, including people who've maybe heard about this project or this pilot and joined us late. How do we get them up to speed and how do we make sure everyone's kind of on the same playing field? Also, as I mentioned a little bit earlier, and I think you'll see it in two slides, is kind of our troubleshooting and kind of support model that we had in place for this pilot, and also when to use and when not to use guidance. If it's a critical or emergent situation, perhaps rely on live translators or escalate it to another person and maybe perhaps a manager. One also like another there's lots of learnings, but another learning that we had was that if we don't implement it well, we can't fairly evaluate the tool. It's a failing then on the implementation and not the evaluation. the implementation plan was built on this foundation, and of course, I had to use pillars to represent it. But these are the pillars that work for our organization around kind of user access and onboarding, authentication, privacy and security, training, and then support. Every implementation is different, and your pillars may differ. But these steps, these foundational steps, were important for us. If there's uneven adoption, if there's informal workarounds that are still happening, or if there's unreliable data that you're getting out of the pilot, or out of the tool, these pillars kind of really supports the project. Also supporting the project, and Atlas is over there, is the team that's required. And I thought very strongly not to put the Avengers Assemble GIF over here, but really making sure that pilots do not stall, and there's no point in the pilot where everyone is like, well, who's doing what and what is going on? We quickly, and this is a brief snapshot of kind of what we did, was came up with common issues that may happen. Who is the first line in kind of supporting them? And then if there's an escalation path needed, who is that escalation path and what happens? For example, there was an issue that we had where I think on iPhones, if you press the spacebar twice, it adds a period into the conversation or into the text. But then it also adds a space. So it's a period and a space. But the space is not the same as hitting a space bar. And I would have never seen this I never thought about this in a million years, but it's actually a different character that represents kind of a blank. And when one of the solutions was using, or when one of the solutions encountered that through an iOS device, the translation didn't work and the translation froze. And so, quickly within a day, we escalated the issue. We documented how it happened. We replicated how it happened, and then we sent it over to the technology partner, who then actually stayed up and tasked the dev team with fixing the issue. And I think within 10 hours, that issue was fixed. It may not be like the most urgent, may not be like the most critical, flag that was raised for someone when they're translating, but it was important, and also demonstrated to us that, wow, we really value kind of quick turnaround times and our technology partners to validate and support the issues that we also face as an organization, or the stuff that we escalate is the stuff that our technology partners also escalate. We also kind of, as I mentioned, we're thinking during the implementation plan and creating the implementation plan is how we're going to evaluate kind of fit within the organization. So that decision criteria that our innovation advisory committee, our cross-functional committee helped inform, also helped inform kind of our evaluation criteria. So we used work that was previously done and added on to it. As we're looking at the solutions, we're thinking, oh, does this one make sense? Does this one not make sense? And then we translated that criteria into kind of, well, does it work for our organization or does it not work for our organization? Many questions, as I mentioned earlier, also came up over here, like usability and accessibility. How easy is the application to use? Can it support the different methodologies of, ones if you hold up your phone and you want to describe how to do an exercise and what it is to do a squat? Can it, look at an image, translate that, and then you show it to someone, or they have it on their device of how to do a squat on a paper-based form or on their screen. Reliability, does it work without Wi-Fi? Does it work with low battery? Does it work with a dim screen perhaps? Perceived accuracy, so like that translate back was important to us. Sustainability, and this is I think very organizational facing of what will it take to sustain the solution, what supports are needed, who's the owner after kind of the pilot is done, or if we're going to scale it, and what about scaling it? How does the scale, like what does that scaling pathway look like? What integrations are required, if any? All these questions are important to think about and to use to kind of evaluate the solution. Lastly, of course, is safety. Where is using this tool inappropriate or unsafe? I mentioned this a little bit earlier, but our evaluation approach was primarily kind of through interviews. We used a structured set of predetermined questions, some of the questions before, some more questions. I'm talking at a very high level of the report that we made, but a very kind of high level, a very structured set of predetermined questions were used. Questions that combine both qualitative prompts as well as quantitative ratings measured on a Likert scale from 1 to 5. And also interviews were audio recorded and transcribed through Microsoft Teams. So we had kind of a very good, rich interview kind of transcription base to go back into theme and to kind of look at the interviews that we had. What we found, some findings and some understandings. I know I'm a little bit here under time, but here's kind of where we found AI translation worked best. It worked best for short, routine interactions. So basic needs, appointment logistics or simple care instructions were kind of the best, where AI translation worked best. Lower stakes clarifications too were also an area where AI translation really excelled, as well as kind of quick rapport building when language is a barrier. One thing that's always fantastic is seeing someone think and understand and realize the context in which they're in and how to communicate the essential information to another party. Um, I always appreciate whenever I don't understand something, perhaps it's a new concept to me, someone taking the time, pausing even, and translating into terms that I can understand. And the same thing works for translation, right? You're translating terms into something else. What we also found was that the deployment of this AI translation tool also increased staff confidence in their care over time, because now they had a reliable way of translating what they needed to say into a language that their clients could understand. Equipping our staff with this new tool was a confidence booster. A little bit kind of some numbers over here of kind of confidence communicating with clients, as I just mentioned, increased from 2.6 before to 3.8. They also recommend kind of using translation apps had a slight increase of 3.9 to 4.3 out of 5. We actually raised up to our partners in the pilot that these languages, I think Hindi was the big one, and I think Cantonese was also another one where translation wasn't the best, or a certain dialect needed to be added. And over the course of the pilot, our technology partners actually added 8 languages, which was absolutely fantastic to see. It also had a positive impact on workflow, where our staff actually said that they rated it a 4.1 out of 5, that it did have that positive impact. I do also want to say that AI translation tools also are becoming more equitable and more culturally kind of respective of different languages, and way more so than Google Translate, in the sense that some languages, because they're gendered, and because also age kind of makes a difference in some languages. I think Korean has that, where if you're talking to someone older, you use different words, and if you're talking to someone younger, you use different words. Or if you're talking to as a male talking to a female, or as a female talking to a male, you use kind of different words. And so some of the language translation solutions that we looked at, Mabel Care to Translate, did that. They actually asked really kind of 2 or 3 questions before you started translating, about yourself and about who you're talking to. And of course, you can put in, I don't know, or it doesn't matter, or skip, or just X, just exit out of that little prompt. But when you did fill out that information, it took that into consideration. And so the translation was much more aligned with natural kind of speaking in that language, or natural conversation in that language. Um, I'm taking off my rose-tinted glasses over here and not saying everything was sunshine and flowers, but adoption in the real world is kind of rough. Login friction kills momentum. We had a couple participants who couldn't log in within the first day, and the second day, they were like, I don't want to be part of this pilot anymore. I don't want to use the solution. I'm just going to use, my old methods of translating it. And, it's kind of a wake-up call to make sure that everything is smooth and everything works kind of within the workflow of our clinicians. There's also really a time pressure at the point of care that affects uptake. How fast, does the app open? Does it take 30 seconds to load, right? Does it take a minute to load? I'm sure that if you refresh your Facebook feed or your Instagram feed, if it refreshes for a minute, you're like, this is too long. I might as well do something else in this time. And really maintaining that, that short, really quick, readily accessible translation solution is important. Also, that, as I mentioned, I can't stress this enough, but the confidence and that validation really kind of needs really drives satisfaction. Making sure that what I say is what is actually said really kind of makes our clinicians satisfied. And also that adoption varies by role, scenario, and region. You know, it's very I guess easy to see but hard to think about. But different areas of Toronto, different pockets of Toronto have very high populations of people who speak other languages. And obviously, if you're delivering care in those areas, you will use one language more than another. And this is what we found during the pilot was, different people in different regions used and prioritized different languages. And also that one training is not enough. So having that onboarding session and saying, this is how you use this language translation tool, it's great, but it's not enough. Sending reminders, sending prompts of like, hey, did you know I can do this as well? Or showing new features is important, and that reinforcement really matters. I had to include this GIF. I love this GIF, but I do want to say that use AI translation kind of with caution. Long, emotional, or complex clinical conversations are very hard for translation tools to translate. It's very similar to throwing into, ChatGPT or throwing into whatever AI large language model you have, a lot of data, a lot of queries, and then asking multiple repeated queries to it. The AIs sometimes hallucinate or forget what that initial question was, or a minute question that you had maybe within that wall of text. And the same thing works for translation too. Having a long conversation, if this entire webinar is translated all at once, it may not do a fantastic job. But if every sentence is translated individually, then it may do kind of a better job. High stakes, kind of, as I mentioned multiple times, consent discussions are important when it comes to translation and making sure that the client knows kind of what they're consenting to. And then also kind of situations requiring nuance and cultural mediation are, where you want to apply some caution when you're using it. Lastly, and like the last two things over here are kind of around when there's background noise or accents and how that affects transcription quality. Some some AI translation tools actually take into account when someone's speaking with a specific accent and then automatically translate back into that accent. But not all of them do that. So, definitely be a little bit cautionary when thinking about that. And then also, as I mentioned, I think a number of times, and this is the last time I'll mention it, is when staff cannot validate that meaning confidently. So here it is, the repeatable approach. I think this is where you can screenshot this, where you can see what we did as an organization and if it works for you as well. But we started with kind of that, defining that problem, really gauge that willingness and readiness for change. We scanned the solution categories. We applied our criteria, had those structured demos, took those structured demos, had them, again, with a cross-functional team across the organization. It also provided as buy-in for the organization and realization of why translation is needed. We implemented with, real support and real people. We evaluated with practical measures built both by our quality teams as well as our research teams. And then we made a decision on our next step because, a pilot is just a pilot. And what happens at the end of the pilot? Do we scale? Do we iterate? Or do we stop? And I'm very, happy to say that we have decided to scale and expand the pilot to more users this year. So we had 40 users for this project, which looked at 3 different solutions. And we've decided to scale up to, I think it's 150 users in 2026 with one solution and learn from there. There's an internal white paper, as I previously mentioned, and the intent of that was to produce a clear organizational recommendation based on our pilot findings. I'm happy to chat with you guys and talk about it. And with that being said, I do want to thank everyone also for their time. I know that maybe perhaps you're eating, maybe perhaps you just wanted to tune in to this. But thank you for making the time to hear about me talk about this pilot. I'm very passionate about AI translation and new innovations and new technology. And I would love if there's any questions to feel free to ask it. Thank you.
Great, thank you, Jordan. So we have some congratulatory messages in the chat for you, Jordan. You might want to look at those. As I mentioned, people can post in the chat or in the Q&A box to ask questions. I really appreciate how practical and human-centered your approach is, and how you've given people tools to take away to understand how it could be repeatable. I say reckless. I can't say it.
Replicable, yeah.
Yeah. um, Within organizations, with lots of caveats involved, right? With the implementation process always being one that's very specific to the organization. And fantastic. So we'll start with some questions.
Of course.
So Mark was asking, who are the user partners you're referring to?
Yeah, so the user partners, as in kind of the people participating in the pilot, so they were our workforce. Primarily they were PSWs, so personal support workers, but we did have some occupational therapists as well as some physical therapists in the pilot program. And it was important for me running the pilot to make sure that we had a semi-diverse user base because not everyone uses the same elements of translation. For example, a physical therapist might translate, a set of instructions on a paper-based form, whereas a PSW may just use the conversational translation element. So the users of the pilot project were different stakeholders within the organization. Yeah.
Great, thank you. We have, looks like there's some in the Q&A box. Thanks for posting, everybody. Okay, so we have a question about how home care can be in an uncontrolled environment, and how do you gather feedback from point of care staff in a way that is representative of diverse care settings? And does this implementation approach differ based on specific home care environments and where the translation skills or tools will be used?
Yeah, that's a fantastic question. I think a way that is not only representative of diverse care settings, but also respectful of our care providers is that through this pilot and through the funding, we're able to pay participants for their time in this project. I think that's very important that when you use someone's time, being respectful of their time in this day and age means paying them for their time. And that's what we did with all the participants in this project. So all the PSWs, all the OTs, and the PTs, reimburse them for their time spent on this, and then also kind of making sure that it was representative of diverse care settings was we contacted and we recruited from across all of our different regions. So we have a couple regions we have a couple different delivery sites, such as the Champlain region, where we do rehab care, or the London region, and we recruited from there as well. So making sure that we weren't just hyper-focused into maybe Central East Toronto or just the West region, but all regions and all kind of roles and provider roles as well.
And then related to that, talking about diverse settings, was this used with individuals living with dementia?
That's a great question, and one thing that was definitely kind of a shortcoming of the pilot was looking into kind of the end users or the people that were using the translation, to translate to. And I really wanted to capture and have some of those interactions, have some of those conversations, but with kind of dealing with delivering care and then interviewing someone in another language was a little bit much, but it's definitely kind of on the radar for this year to kind of take that into consideration and really look at it from an end user approach. As a person receiving care from VHA, speaking another language, do I feel like my care needs are being translated and captured appropriately? Yeah.
Yeah, it's important to get that, really important to get that feedback as well.
Yeah.
And I think you're really lucky in that you have your Innovation Advisory Committee, and I
Yeah,
assume that committee includes older adults and
it does.
patients, and
Yeah.
yeah, and that's an important part of the process as well. Yeah. Okay, so some other questions. Thanks for bringing your questions in, everyone. Really appreciate that. In terms of piloting, do you believe your criteria for pilot success and acceptance of new technology will translate into small startups launching new products as well? And what advice would you give to new startup founders piloting a new project in Ontario?
Oh, that's a great question. One thing that we did look at is the maturity of the organizations and the technology partners that we worked with. We love to see, startups. We love to work with startups, but perhaps on a smaller scale. If we're looking at scale up to an entire organization, one thing that's really important for our organization is making sure that they have kind of that lifespan and then that they have that maturity that can last, 5 years, 10 years down the line. Because if I'm looking at translation today, and it's a small company of two or three people, will that company still be around in 5 years? Or will someone have to redo this entire process, doing an updated scan, doing updated metrics in 5 years to kind of understand what the best solution is at that time? The advice I'd give to kind of a startup founder piloting this project in Ontario is uh, don't, I mean, it's a startup, but don't shy away from smaller projects. Even if it's a sample size of five, even if it's a sample size of two, getting those use cases and building that portfolio of this is where it worked and these are the people who use it and these are what they have to say, I think is absolutely essential because that's one thing that I always look for is like, who has used this before? Can I talk to them? Did they like it? Did they not like it? And then we get into kind of discussions of what it means to pilot and to scale.
Great. And also building that database, I guess, of
Yeah.
results and yeah. Okay. Great, thanks. Okay, question from Charlene, which I think this is a great question too. She's curious to know if VHA or the company analyze conversations to glean further insights. For example, the most common topics or languages. It would be neat if VHA could use that information to create supplementary resources to further support frontline staff in their communication. So even, those take-home exercise sheets. I think we've all seen those if anyone's gone to, PT or anything. Um, what kind of information are you putting together and are you using that to create other
Yeah.
resources?
So analyzing the conversations like in depth, we haven't. That's like a privacy and security like concern. But looking at like those most common languages or like those most common phrases that were translated is something that we have done. As I mentioned kind of earlier, it varies region by region, and I think 40 is not the biggest sample size to kind of dig deep into that information. Of course, if five of those people were delivering care in a specific region, then they would use this language more often than not. But getting that holistic, getting that organizational wide picture is what we're planning to do this year. Um, Creating that supplementary kind of information, creating that package is important, and I believe actually our welcome package to VHA has been translated into a couple other languages, and they are our most commonly spoken languages. So we have done some research on language concordant care in the past, and we are actually also refreshing some language concordant care research right now to understand like our users, our clients, and what languages they speak. Yeah.
And someone just asked a question about using this with people with different literacy levels or speech impairments. So I suppose that's part of the bigger ongoing project.
Yeah, that is part of the bigger ongoing project. We actually had a great conversation. Oh, I forgot the name of this company, but they actually kind of focused in on um, speech impairments. So conversing with people who also have like vision issues or vision problems, or maybe attention problems, and ways that they can communicate. We actually, I mean, this is slightly related translation, but we actually also started looking at Braille, like Braille keyboards, where you can type something in and it pops up as Braille, so that people with vision impairments can kind of understand what that means. Innovation is a wonderful place because I get to see all these new cool and exciting technologies, and we definitely want to make sure that everybody's included in the care that we deliver.
Great. And you didn't name the solution.
Yeah, I dropped the names a couple times. I didn't want this to be too, here's what we're using and go ahead and buy it. But the solution that we've chosen has been, or is called Mabel AI. They're a Scandinavian kind of based organization. We also looked at Care to Translate, which was a very tough second place like contender with an absolutely fantastic kind of phrase library where people can use kind of repeated phrases as well. The main thing is that for us was like, the turnaround time, the conversation, and the nature of these organizations to really support our specific home healthcare needs.
Yeah, and one thing that you mentioned that I was going to ask you about, but it sounds like they covered it, is the kind of interpretation, in addition to just straight translation, that you can put in all these demographic differences so that you can speak to someone in a way that makes sense culturally as well. Is there like, will there be an expansion of that, or is there, the idea that they can skip over that maybe isn't ideal?
Yeah, it's one of those things where like if I travel to a country where I didn't speak the language and let's say I had like a gash on my leg and I wanted to see someone about it, um, I don't care if they refer to me as sir or ma'am. I just care that I, get the care that I need. But if it's something that's not as bad, maybe it's a slight rash that I had, including that those cultural elements are really kind of important, especially as we're trying to be an equitable organization, right? We're trying to make sure that the care we deliver is culturally sensitive as well. And so, we encourage our staff that when they had the time and they spoke one of the languages that, maybe differed based on ages or differed based on genders, that they did fill that. It's not even a survey. It's literally like a quick pop-up prompt that says, who are you speaking to? Who are you? And, is it older or younger that you're speaking to? So it's not this interruption into kind of the translation, but it's more of an add-on. But as I said, yeah, if it's an urgent issue, like I don't care, just treat me. But if it's something that you can take your time with, then yeah, let's, why not? Yeah,
Yeah, and you're trying to build trust and rapport as well,
exactly,
right? So
exactly.
that's
Some
part of the respect.
yeah,
Yeah.
like my grandma received care from the same PSW, I think for 6 years before she I think moved to another organization, and so she didn't want to change PSWs, and there's lots of hesitancy of seeing a new face. And it's very similar to kind of that translation. You want to get off on the right foot if you're seeing a new client because you could be seeing them for a while, and building that relationship and really kind of becoming part of that family unit is what we see a lot of our staff do.
Yeah, I can imagine. There's lots of bonds built there. Yeah. Someone asked if there's results of the pilot. You mentioned a white paper, but it's not published publicly, right?
Yes, that's correct. Yeah, it's more of an internal kind of recommendation document. However, if you kind of do want to see some of those results or have a conversation with me more in depth to see and dig into a little bit more, please do reach out to me. I'm sure you can find me on LinkedIn, and if not, I think VHA does have an innovation page where there's also some contact information. I didn't include on the slide, but if you do want to send an email, it's simply innovation@vha.ca.
Okay, great. And we can include that email when we send out the recording as well, if you don't mind.
Awesome. Yeah, of course.
Okay. And then we're just wrapping up. We're almost at the end here, but there is one question left. So
Of
let's
course.
answer all the questions. And this one, of course, has to do with trust when it comes to AI, right?
Yeah.
So how did you address with point of care staff concerns about the accuracy of AI enabled translation tools and AI in general?
Yeah.
Not everyone trusts it or
That's
thinks it's a
true,
good
and
idea.
I think it's a fair thing to do. One of the things that we did was ensure that all the solutions had that translate back option. So we type in "Hello, how's your day?" It may translate into something, and then it'll actually translate back underneath, what that means. Maybe it's like, "How's your day going?" or "What do you think about the weather?" And making sure that you have that double verification, that translation back was super critical for our staff to buy in and to be confident about the translation that they're having. Especially like as I mentioned, there are a couple words that you can use interchangeably or have different meanings. That translation back really ensures and really gives that peace of mind of what I said is what's being translated. And that was a requirement from our staff, from our innovation advisory committee, that these translation tools need to have.
Yes. Yeah, that's fantastic. Sounds like it had all of the requirements you needed, and then you're just going to keep adding more.
Exactly. Yep.
Yeah.
The bar only gets higher.
Yeah. Well, thank you so much, Jordan, for sharing your pilot journey. I'm sure people have lots of learning, and we'll be taking these things home with them as well as reaching out to you. So thank you so much. Thank you for everyone who attended and for your great questions. Really appreciate that as well. I also posted in the chat, you can find our next event at agewell-nce.ca/events. And on February 26th, we have our next one, and it's actually more about AI. So we've been focusing a lot on AI lately. We're looking at demystifying artificial intelligence. So digging a little deeper into the basics, as well as how this can be applied in real world applications for small organizations. So do register if you'd like to attend. Thank you so much, everyone. I hope you have a great rest of your day, and we look forward to seeing you at our next webinar.
Thank you, everybody.